Hello, everyone. My name is Jim Seberg. I'm the Assistant Director for the Medical Cannabis Research Center here at Drexel University. Today, we are very happy to be joined by Dr. Maurice Hinson. This is founder and director of MediRoots Medical Group, a telehealth-based primary care practice specializing in providing equitable access to high-value primary care. He is also a hospitalist at Jamaica Hospital Medical Center. Dr. Hinson received his Bachelor of Science in Neuroscience from Johns Hopkins University, his MD from Drexel University's College of Medicine, and he completed his residency in internal medicine at New York Presbyterian Weill Cornell. Dr. Hinson is the recipient of numerous basic science research awards, the 2015 Excellence in Public Health Award by the U.S. Public Health Task Force, the 2020 Drexel University 40 Under 40, and was recently inducted as a fellow into the New York Academy of Medicine. His most recent academic interests involved the clinical application of cannabis and psychedelics for the prevention and management of chronic disorders like obesity, heart disease, high blood pressure, diabetes, anxiety, depression, dementia, and cancer. Additionally, Dr. Hinson actively works to increase the number of underrepresented physicians by engaging with and empowering aspiring students in their journey into medicine. Without further ado, I'll turn it over to Dr. Hinson for his great presentation for the potential of cannabinoids for the treatment of cardiovascular disease.
Yeah, very much appreciate the invitation. Once again, my name is Dr. Maurice Hinson, and I'm gonna jump right into it, okay? Because there's a lot of slides. Um, some of it will be pretty detailed, but I want to give everyone the opportunity at the end to ask questions. All right, it's gonna be a lot of information. You may have to watch it a couple of times, but hopefully you'll get something from it and then we can have a discussion afterwards. All right. So the topic for today's talk is potential benefits of cannabinoids and cardiovascular disease. I have no conflicts of interest to disclose. This is just a brief overview of my educational and training. Of recent, became an owner, Quantum Care Medicines, a primary care practice out here in Brooklyn, where I'm able to implement some of these modalities like medical cannabis for the management of cardiovascular disease, hypertension, diabetes. Also, the managing founder of Quantum Well Care, which is instrumental in designing protocols for the use of alternative therapies. And I advise several boards like Health Metrics and their proprietary lung respiratory device and Canon coverage. I gave this presentation earlier this year in February for the Office of Cannabis Management, which is the cannabis governing agency in New York. And I entitled it Clinical Considerations and the Use of Cannabis for the Prevention and Management of Atherosclerotic Cardiovascular Disease. And I named it that for a reason because of all the recent media coverage looking at the negative implications of cannabis for heart disease. And I think it's important to recognize sort of the duality of all things, right? Like everything sort of exists on a spectrum. I don't believe anything is all good and nothing is all bad, but we have to figure out ways in order to use these therapies where they afford the greatest benefit while mitigating risk. The aims of the talk is one, to challenge the current negative perception of cannabis use in atherosclerotic cardiovascular disease. And that's just to refocus our therapeutic approach in the prevention and management of heart disease, inform current and future cannabis providers about the potential uses of cannabis in the prevention and management of heart disease, and to inspire thought and conversation for us to engage in intellectual debate pertaining to quote unquote cannabis use in heart disease. And you'll understand why in a little bit while I'm putting cannabis use in quotations. But just to start out, I have a few questions for the audience. No one has the answer. I just want you to think in your head. But one, what score did you get on your endocannabinoid system test in school? All right. I know for me, we didn't learn about the endocannabinoid system in medical school. And much of what I've learned has been self-taught, either through the literature, New York State's official program, speaking to friends who have been involved in cannabis much longer than I have. And so, a lot of our providers are not educated and trained and equipped to really have this discussion about the endocannabinoid system. And when you think of cannabis, do you only think of THC and CBD? Are you aware that there are hundreds of cannabinoids out there? And so much of what we know and what the mainstream knows is only of these two cannabinoids. And have you heard of the entourage effect? If so, are you a believer? Do you believe it's truth and myth? There's a lot of data which support its existence, but there's still those who question its efficacy and its presence. And are you comfortable recommending cannabis to your cardiac patients? Now, this is for our providers. And what messaging, what content shapes your perception? And the reason why I ask this is because there have been a number of studies recently which have sort of demonized cannabis and its role in cardiovascular care. All right. Everyone from CNN to USA Today, New York Times, Washington Post, there have been, a number of sort of negative takes on cannabis in this role. But then there are others who swear by cannabis, right? It's a lot of people who use cannabis for a myriad of reasons to relax, to help with sleep, to make them feel good, to relieve pain, to improve their mood. And so there's this paradox that exists in cannabis use. On one hand, we're saying it's dangerous for the heart, but on the other, a lot of people use it for conditions that they're dealing with. And so my question is, well, what's the difference between a medicine and a poison, right? When we consider snake venom, I think most people would say that it's a poison. And this is because we know its effects. We can get limb ischemia, anaphylactic shock, death, right? But what some of you may not know is that snake venom was really the source for several of our earlier antiplatelet therapies. It was the source for captopril, the original ACE inhibitor, all right, the antihypertensive. And so, on one hand, we see how snake venom is poisonous, but on the other, it's been used as a medicine. And water, I don't think anyone would consider water to be a poison, right? But if I asked you to drink a gallon of water, like seen here on the left, yeah, you could do it. If I asked you to drink a gallon of water in an hour, you could do it. You might be uncomfortable, you might be peeing a lot afterwards, but you could do it. But that same gallon of water given intravenously may actually kill you. All right. 4 liters of free water might drive your electrolytes to lethal levels. All right. So we see that neither of these is really a medicine or a poison, it's somewhat a combination of the two. And so, really, the difference between a medicine and a poison is the outcome, right? If the outcome is good, then it's a medicine. If it's bad, then it's a poison. And what tends to determine the outcome is the route of administration and dosage. And you'll see these take-home points throughout the presentation. So to go back to where the media was getting some of these findings from. So in 2004, in the Journal of American Heart Association, investigators found that cannabis use, quote unquote, was associated with poor cardiovascular outcomes. And it concluded that cannabis use is associated with adverse outcomes, with heavier use, more days per month being associated with higher odds or adverse outcomes. And this year, there was another huge article, over 4 million patients involved in the Journal of American College of Cardiology. And they concluded that these findings underscore significant cardiovascular risks associated with cannabis use, and that this would reinforce the need for public health initiatives and heighten clinician awareness. Now, these weren't new studies. These actually sort of corroborated a number of studies which exists in the literature. This is a meta-analysis looking at significant association between cannabis use and cardiovascular risk. And some of the proposed mechanisms for this increased cardiac risk include cannabis arteritis, which is an autoimmune mediated vasculitis, particularly with the arsenic, all right, the presence of arsenic. We've seen coronary vasospasms, platelet aggregation by way of high dose THC, pro-inflammatory cascade induction, and THC mediated sympathetic activation, all right, which tends to occur in a dose dependent manner. But then there are a number of studies which show no association, right? Here's another large study of over 3,000 participants, which showed no association between cannabis use and coronary artery risk development. Another study of close to 14,000 uh, didn't show an association. And this study I included because this used genomic information to see whether or not cannabis use was associated with increased cardiovascular risk. So sort of taking away some of the biases involved in survey data and retrospective analyses. And essentially what they did was they used 64 independent small nucleotide polymorphisms, which were changed in patients that use cannabis and overlapped it with other genetic downstream targets in patients with cardiovascular disease and found that there was no significant causal association between these SNPs and coronary artery disease or ischemic stroke risk. So why the inconsistency in the data? And really the answer is because most of these studies fail to really appreciate the unique properties of cannabis and stratify their methodologies and their studies accordingly. So let's briefly talk about the endocannabinoid system so it starts to make sense. The endocannabinoid system is a major regulatory system within the body, if not the most critical regulator within the body. All right. And it functions throughout all of our systems. Our endogenous cannabinoids are AEA and 2AG. And again, they have implications on a myriad of physiologic processes within the body. Here's a schematic showing its involvement in heart function. We see everything from chemotaxis to vasodilation, constriction, increase or decrease heart rate. And so it has profound implications on heart function. Phytocannabinoids are essentially cannabinoids that are found in plants. Okay, we have endogenous cannabinoids, the AEA and 2AG, and then we have phytocannabinoids like THC and CBD. And most people know these to bind to our CB1 receptors and exert their effects. This is a schematic showing the various pharmacokinetic and dynamic implications of cannabis consumption. Okay. The beauty and the curse about cannabis is that it can be used in so many different ways. You can inhale it, you can ingest it, you can apply it topically, you can ingest it orally, and it has one sort of onset time and duration, or you can ingest it sublingually, which tends to act faster and have a comparable duration of action. All right, so there aren't many drugs in the market. I don't know of any actually, which has this type of versatility. And then to make things more complicated is this maturation and conversion. All right. CBGA is the mother of all cannabinoids. From that, we get THCA, CBDA. All right. And when we apply heat to these acidic forms, we cause the decarboxylation of these cannabinoids. And each one of these various cannabinoids have their own mechanism of action and end effect. This is just a schematic showing the temperatures needed to result in decarboxylation of cannabis. All right, so we go from the acidic form, which is the raw natural form, to the neutral form. All right. And it takes these temperatures at a certain amount of time in order to result in complete decarboxylation of these cannabinoids. And then these cannabinoids don't only target the CB receptors. All right. They have a number of other downstream targets like TRPV receptors. We've got ion channels. All right. And so it has an extensive reach when it comes to therapeutic effect. And just to add another level of complication, we have hundreds of cannabinoids. We've got thousands of terpenes. Each one of these terpenes, and it's really the terpenes that give the cannabis its unique characteristics, its smell, its taste. All right. But these terpenes have their own physiologic effects. All right. Antibacterial, anti-inflammatory, antifungal, analgesics. It's just a number of different physiological effects that exist with these terpenes. Then we've got dozens of flavonoids, all right, each with their own, again, physiologic effects. All right, so we see just how many combinations of these things, these compounds, that could lead to different effects within the body. And this is more so about the processing and what end product you're getting, right? We have full spectrum, which is really everything contained within that plant, from the cannabinoids to terpenes to flavonoids, waxes, lipids. Broad spectrum is basically full spectrum just without THC. And then isolates only contain the cannabinoid. Okay. So, what really grinds my gears is when I see in the literature these blanket statements like cannabis use, and then they have these conclusions that really sway public opinion, but what type of cannabis use? What are we really talking about? How are they consuming it? How was it processed? What dose are we giving? I have listed ultra low, low, moderate, and high, but we don't even have as an industry, we don't have a standard for what this means. And so this becomes critical when performing research and coming up with these conclusions. In fact, when you go back to these studies, like this one that was published in 2024, and you go through the supplemental data, you find that 74% of the participants reported smoking cannabis as their primary method of consumption. Now, if you smoke anything, you're going to increase your cardiac risk, okay? Because you generate free radicals and reactive oxygen species, which are pro-inflammatory and potentially carcinogenic. You start generating these volatile organic compounds like formaldehyde, which again are pro-inflammatory and potentially carcinogenic. You produce carbon monoxide, which reduces oxygen delivery to tissues in need. All right. And so this is true of smoking any type of organic material. You will generate these pro-inflammatory and potentially carcinogenic compounds. And when you go back to this study that was just published that looked at, over 4 million participants, even the authors themselves said that this study has limitations due to lack of detailed cannabis consumption data and potential misclassification. Well, that changes everything. If we don't have detailed information about their consumption habits, then how can we really generate any real conclusion? Okay. And so I don't oppose their findings. I'm just challenging the conclusions because they were not appropriately stratified. And so future cannabis research must stratify their methodology by chemotype, processing, route of administration, dose frequency, chronicity. All right. These are critical factors. These are critical variables which alter outcomes. But let's get into heart disease. Okay. Some of the key mediators of atherosclerosis include inflammation. Okay, we're learning more and more now that atherosclerotic cardiovascular disease is an inflammatory disorder characterized by intravascular plaque formation. All right. Its risk factors include the metabolic syndrome, inactivity, smoking, and that this formation, this plaque formation, is accelerated by heightened and chronic sympathetic activity. And more recently, researchers have identified this NLRP3 inflammasome as a novel target in the prevention and treatment of atherosclerosis. And when we talk about the metabolic syndrome, I think one thing that has to be understood is that what's central to all of these disorders, heart disease, high cholesterol, hypertension, type 2 diabetes, dementia, they're calling Alzheimer's now type 3 diabetes, okay, cancer, PCOS, fatty liver disease. What's central to all of these disorders is insulin resistance and inflammation. And we're learning that each of these sort of influences the other. Inflammation causes insulin resistance, and insulin resistance is pro-inflammatory. Okay, we know that smoking increases both of these, and what may not be as well understood, but makes sense when you think about it, is that one of the other potent drivers of insulin resistance is insulin itself, right? This is what our bodies do, right? When it's constantly exposed to something, it becomes desensitized to it and therefore has to produce more of it to exert the effect that it wants to have. All right. And we have data which suggests that hyperinsulinemia may actually precede the development of insulin resistance. Okay. So when we really boil down to it, we need to address these underlying causes for these risk factors. All right. And when you see what we do in practice, you see that our therapeutic approaches are a bit misguided. Taking type 2 diabetes, for example. We diagnose and we treat the sugar, right? We diagnose diabetes when your A1C is greater than 6.5 or your fasting glucose is greater or equal to 126, right? It depends on blood sugar level. And we're targeting an A1C less than 7. Okay, remember, A1C is an indication of your average blood sugar levels over 3 months. And so what we're doing is treating symptoms, okay? This elevated blood sugar that we're seeing is not the disease itself, is actually the symptom of the disease. And we know that treating symptoms only allows the real problem to persist. In fact, we've learned from the Accord study that when you target blood sugar, and in this way, what they did was they separated two groups of people, had one in standard therapy, which was like one uh, diabetes medications versus intensive therapy, which was a myriad of insulin and glitazones and metformin and other sulfonylureas and other hypoglycemics. They were able to achieve a lower A1C through intensive therapy. However, it resulted in significantly increased cardiac death. All right. So when we target the sugar, it ends up resulting in increased death. And so this highlights the need to address the root cause of these problems, which again tends to be insulin resistance, inflammation, and sympathetic overactivity. All right. Now, is it possible for us to frame cannabis with this myriad of consumption methods and reducing the impact of these the root causes of atherosclerotic disease? And that's what I'm going to go into in the subsequent slides. So these are some of the cardiac related properties of cannabinoid isolates. All right. First, we'll start with THC, which is usually the more popular cannabinoid. What we see consistently throughout the data is that THC increases heart rate in a dose-dependent manner. That's sort of across the board. Okay. What tends to be a little more mixy is his role in blood pressure control. Some studies say it increases it, others say it decreases it. Generally, THC is thought to improve insulin sensitivity and increasing insulin production. And its role in inflammation is mixed as well. Okay. I'm including this study here that used a rat model, a mouse model rather, with LDL receptor knockout mice. And they gave these mice, or they fed these mice a high fat diet for several weeks, and then treated them with delta 9 THC, given 1 milligram per kilogram intraperitoneally. And they did this with or without genistein, which is a CB1 antagonist. All right. And they found that delta 9 THC at 1 milligrams per kilogram intraperitoneally actually increased the plaque area in these mice. So it actually increased atherosclerosis. All right. Whereas in this study, the researchers used 1 milligram per kilogram of THC, but this time it was given orally. And this was a ApoE knockout mice model. And they found that THC actually reduced plaque formation. Okay. So this highlights that it's really the poison is in the dose, right? We have, even though the doses were the same, the route of administration was different. Intraperitoneal administration is effectively like giving something IV. You get 100% or at least near 100% bioavailability because you're bypassing first pass metabolism. Whereas with oral administration, you're only getting about 20 to 40% bioavailability. And therefore, the plasma concentration of THC given orally is substantially lower than giving it intraperitoneally. Okay, and that's what it seems to be all about. Here I'm looking at CBD and atherosclerosis. Again, there's mixed data here with regard to its effect on heart rate. For the most part, it tends to lower blood pressure. What seems to be pretty consistent is that it improves insulin sensitivity, it lowers cortisol, and is actually one of the more profound anti-inflammatory cannabinoids that has been studied. On the right here is just a schematic showing um, coronary artery endothelial smooth muscle cells that were treated with platelet-derived growth factor with or without CBD at varying concentrations, and he found that co-administration of PDGF with CBD significantly reduced platelet migration. All right, and which suggests that you would have reduced plaque formation. Okay, because these plaques are tend to be driven and formed by platelets. Okay, looking at CBG, the mother of all cannabinoids. There isn't much data suggesting much change in heart rate. But we do see several studies showing that CBG lowers blood pressure in a dose-dependent manner. And this is by way of activating the alpha-2 adrenergic receptors. Okay. What's also pretty consistent is its role in improving insulin sensitivity and its anti-inflammatory role. On the right, it's just a schematic looking at the blood pressure at varying doses. All right, we see this dose-dependent response with CBG administration. And at the bottom here, we see CBG with or without uh, atipamezole, which is a selective alpha-2 adrenergic receptor antagonist. So we see that it reverses the blood pressure suppression of CBG. Here we're looking at THCA. Okay, remember THCA is the acidic form of delta 9 THC, the native form of THC. And we see that it attenuates the metabolic disease caused by diet-induced obesity. All right, so here the investigators used a mouse obese model, and they found that administration with THCA resulted in significantly decreased weight, inflammation, and increased thermogenesis. So meaning increased energy expenditure, because they found that THCA actually induced browning of white adipose tissue. All right, so brown fat tends to increase energy expenditure. THCV, which is one of my favorite cannabinoids, one that I'm particularly interested in, just given my diabetic programming, it's been found to decrease serum insulin concentration and improve insulin sensitivity. Okay, what we have here are studies using atherosclerotic mouse model, all right, and looking at varying doses of THCV. And what we find is that the plasma concentration is significantly decreased in a dose-dependent manner in mice that were given THCV. Okay, on the left is 5 hours in the fasted state. On the right is 30 minutes after glucose test. Okay. This figure G here is showing the HOMA IR, which is a marker of insulin resistance. This is how we quantitate insulin resistance. What we find again is that mice that were given THCV, especially at this 12.5 milligram per kilo dose, saw a significant decrease in insulin resistance. Now, this is in the fasted state, figure G, and figure H is 30 minutes after glucose test. All right, so once again, we see significant decrease in insulin resistance, or another way of saying that is improved insulin sensitivity in mice that were given THCV. Additionally, we see that THCV resulted in decreased weight gain. And this was done by way of decreased food consumption. Again, these mice these atherosclerotic mice models were given THC, and then their weight was measured a day after administration, and he found significant decrease in weight gain in the THCV fed mice. All right, and again, we see that's mainly because these mice ate less. All right, so we have a hypophagic response in THCV fed mice. Okay. What I didn't include here is the fact that THCV also increases GLP-1 expression. So there's this huge wave of these GLP-1 injections. Well, THCV actually modulates GLP-1 expression. All right, it's another one of its mechanisms of action. This schematic, I'm just showing like all the different anti-inflammatory and cardiovascular risk modifications that these neutral phytocannabinoids have. Remember, neutral implies that these are the cannabinoids after decarboxylation. All right. So THC, CBG, CBN. I didn't speak about CBN, but CBN has been found to reduce hypertension. I didn't discuss CBC, but CBC also has potent anti-inflammatory effects. Okay. A similar schematic, except this one is showing the acidic phytocannabinoids. So acidic is before they were decarboxylated. These are the native forms. And once again, highlighted are the anti-inflammatory effects or the cardiac effects of these acidic phytocannabinoids. And here we have the varinic phytocannabinoids. So your THCV, your CBDV, your CBGV. And once again, highlighted are the anti-inflammatory and cardiac effects. All right. So we see that these phytocannabinoids have extensive implications on the role of atherosclerotic development. So in summary, each cannabinoid has a host of downstream receptors which determine its cardiac effect. The cannabinoids which were studied appear to have benefit improving insulin sensitivity. CBD, CBG, THCA, THCV, and low dose THC. All right, we have to specify. Low dose THC appear to have potent anti-inflammatory properties. Okay. And so those were in the isolate forms. I want to speak briefly about full spectrum extracts, okay? Because there's a slew of data that shows that the efficacy of full spectrum extracts may differ from those found in isolates. In this study here, we were looking at a cell model where they induced inflammation by way of administering LPS, lipopolysaccharide, all right, either with CBD isolate or THC isolate or their full extract forms. Okay. Figure C is looking at IL-6. And what we see is that LPS is decreased in the CBD isolate treated samples, but is significantly decreased in the whole plant extracts and the full spectrum extracts. Okay. And that's true of the other markers of inflammation as well, MCP1 and IL-10. On the right, we're looking at THC. All right. We're looking at what happens in the presence of LPS and THC. We see once again that THC isolate here at this dose did decrease um, IL-6, but the extracts, and here they use two different extracts, substantially decrease the expression of IL-6. And this is true of the other inflammatory markers, MCP1 and IL-10. Okay. Now, is this due to the entourage effect? I don't know. But what this is showing is that full spectrum extracts have superior efficacy in reducing inflammation. And here's a study looking at full spectrum CBDA extracts in a zymosin-induced inflammatory model. And he found that full spectrum extracts were able to suppress zymosin-induced TNF alpha in a linear dose-dependent fashion. Now, why is this important? Well, in order to answer that, I have to break down each one of these figures. So in figure A, we're looking at CBD isolate administered intraperitoneally, and we see this biphasic expression, right? Where at moderate doses, we see suppression of TNF alpha, but at low and high doses, it returns to baseline. Okay. So again, on the x-axis is the dose of CBD, on the y-axis is the serum concentration of TNF alpha. All right. And again, we see this biphasic response in the CBD isolates. Whereas in the CBD extracts, we see a linear dose-dependent reduction in serum TNF alpha. So as you increase in dose, you continue to decrease in serum TNF alpha expression. The bottom two graphs are looking at uh, oral administration. Okay. But once again, oral administration of CBD isolate resulted in this biphasic response, whereas oral administration of full spectrum CBD extract resulted in this linear dose response. And this may actually be exponential, you know. So the point is full spectrum extracts have a broader therapeutic effect, all right? Um, But this is also a reflection that dosing requirements depend on the route of administration. Okay. You see, we needed substantially higher doses of CBD and extract in order to achieve a comparable suppression to intraperitoneal administration. That CBD isolates tend to exhibit this biphasic response when modulating TNF alpha levels, whereas full spectrum CBD exhibits a more linear dose response in its ability to suppress TNF alpha. Okay. And so, how can we combine all of this to impact the future of uh, cannabis and its role in the prevention and management of atherosclerotic cardiovascular disease? Well, again, to take it back to what I mentioned earlier, there's a lot of new studies coming out looking at this NLRP3 inflammasome and its role in the development of atherosclerosis and how the pharmaceutical industry could use this as a potential novel target in its management. Well, what we find is that THC and CBD suppress LPS-induced NLRP3 expression. Okay, here we have LPS and ATP in order to induce the NLRP3 inflammasome expression. But in the presence of CBD and THC isolates, we see a significant reduction in expression. All right, so this shows that THC and CBD are direct inhibitors of this NLRP3 expression. Here's another model of increasing NLRP3 expression. This is using UVB light. And what we see here is that full spectrum CBD extract reduces UVB induced NLRP3 expression. All right. So in the previous slide, we showed that the isolates reduce it. Here, we're showing that the full spectrum extracts reduce it as well. But how can we make this more pertinent to what we're talking about? Here we're looking at UVB. The other model, we're looking at LPS. Well, there is evidence that the Western diet triggers NLRP3 dependent immune reprogramming. Okay. Here, the authors used an atherosclerotic mouse model using LDLR receptor knockout mice, fed them Western diet, high in fat, and found that it significantly increased systemic inflammation. However, when they created an LDLR knockout mice and an NLRP3 knockout mouse, fed it a Western diet, they saw lower expression of systemic inflammation. And so the authors concluded, and I'm going to read it here, that in summary, Western diet feeding can result in a remodeled cellular compartment in the bone marrow, leading to increased proliferation, skewing of hematopoiesis, and generating exaggerated responses to exogenous and endogenous triggers of inflammation. By integrating the inflammatory effects of Western diet, the NLRP3 inflammasome appears to be critical for this response. Hence, this may pave the road for new therapeutic cardiovascular disease interventions, such as the use of small molecule inhibitors that block the NLRP3 signaling pathway. And here is where I see cannabis playing a major player. I just spoke about its role using THC, CBD isolates, as well as full spectrum CBD extracts, and how it was able to suppress the NLRP3 inflammasome. So, in summary, cannabis appears to offer immense potential in the prevention and management of heart disease, particularly in its ability to suppress the NLRP3 inflammasome. It appears that full spectrum extracts, possibly more of the CBD leaning extracts, potentially offer the greatest therapeutic benefit because they have a broader therapeutic range compared to isolates. But that the only way for us to determine this is to engage and conduct more direct comparative research, stratifying for these different variables, chemotypes. I didn't even talk about the chemotype with terpene combinations, stratifying by route of administration, formulation, and dose. This is absolutely critical in order to determine efficacy and safety profiles. All right. So again, this is sort of the beauty and curse of cannabis, the fact that we have all these different combinations and all these potential effects. But this is what allows us to bring back the art of medicine. All right. I don't believe that cannabis is going to be a one size fits all type of therapy. This is where we can really enhance and practice personalized and individualized medicine. But I do think this offers a huge avenue and new wave of addressing cardiovascular disease. And with that, I thank you for your attention, and I will gladly answer any questions that you may have. Thank you.
Thank you, Dr. Hinson. That was a great presentation. Do have a question in the chat here as well that I wanted to ask first. You said that smoking anything increases cardiac risk. However, we know that cannabis can be neuroprotective based on government patent and also pneumoprotective since no lung cancer cases are associated with even heavy long-term cannabis use by smoking. Isn't it also possible smoking cannabis can be cardioprotective?
Yeah, we were sort of discussing this before everyone joined. I for one would not suggest it. I would not suggest smoking cannabis in my cardiac patients for several reasons. Several which I named already. Anytime that you have THC and you're smoking THC, you're resulting in the decarboxylation of THCA into THC. You are directly activating the CB1 receptor. The CB1 receptor, there was a paper that came out recently showed that the CB1 receptor forms a heterodimer with the beta adrenergic receptors. And this is likely the reason why activation of CB1 by THC causes increased heart rate. All right, because we do know that the beta receptors increase heart rate. Now, anyone who is at risk for heart disease or who has a history of coronary artery disease, you do not want to increase that patient's heart rate. You do not want to increase that patient's cardiac demand. That's what triggers and can lead to myocardial infarction. And so I would heed caution. I do think there may be, is there potential for safe smoking? I don't know. There is a window between decarboxylation, all right, which occurs at what, 150 degrees C or whatever it was, and the generation of volatile organic compounds, which tend to occur around 180, 190. But again, even though you're reducing the amount of volatile organic compounds that are produced in reactive oxygen species, you're still causing the decarboxylation of THCA to THC, which is going to increase heart rate.
I'm going to pass it over to one of our team members. Sandhya, do you want to go over your question?
Yeah, thank you, Jim. Maurice, really great talk, very informative. As a pharmacologist, this is my nightmare, right? It has too many targets, too many functionalities, too many downstream metabolites. And so where do you think FDA will take this? I mean, we still don't know what path we can take with these compounds. And they are still extracts. They're not single compounds, right? So, as a physician, where do you see this being used and making it into the main drug industry?
Yeah, so I think in terms of making drug therapies out of full plant extracts, I think that's going to be challenging, right? Because it's challenging to standardize, it's challenging to scale. But I think, and this is more of a philosophical answer. I think the days of monotherapy of these single target agents are coming to its end. All right, because when we look at just the examples that I gave here, if you're able to achieve greater efficacy at a lower dose, now you're mitigating side effects. And granted, we may not know all the different targets, but somehow it works. All right, somehow it works. And I guess to give an example of an agent which has this has this comparable effect of targeting multiple receptors, look at what we're using for refractory schizophrenia. You know, clozapine seems to be the only real therapy that works. Clozapine, from a pharmacologic standpoint, is an incredibly messy drug,
Yes.
right?
Mhm.
But it works. It works. And I think the reason why it works is because when you have when you target multiple receptors and multiple pathways, you allow for a greater ability to balance the
Yeah,
system.
but clozapine doesn't have as many downstream targets as this. Not even just the receptors that you're talking about. When you go
Sure,
to the metabolic profile,
sure,
you
sure.
activate xenobiotic receptors, aryl hydrocarbon receptors. That's where you're getting your NLRP3 functionality coming through the
Sure,
aryl
sure,
hydrocarbon
sure.
receptor.
Absolutely. But it's the only one that we have that's somewhat comparable to what cannabis is doing. And
Yeah.
so no, I agree with you, but I think, and again, this is more philosophical than it is scientific, but I think what disease is presenting itself to be is more of an imbalance of endogenous pathways. And so by targeting one pathway, you're going to throw off another one entirely. But if you have a compound which hits these various pathways, perhaps you don't throw off that system so dramatically and you allow a greater chance for that system to reestablish homeostasis. Because that's really what it's all about, resetting the body to achieve homeostasis.
Thank you.
Another question from our one of our members on the team, Dr. Ben Cocchiaro. He said, as a primary care physician, I sometimes hesitate to bring in evidence from animal studies when counseling patients about cannabis. How does your understanding of this literature in the sad state of human cannabinoid research find its way into your guidance with your patients?
Yeah, no, I mean it's a great question, and it's one, it's impossible to answer, without the descheduling. I prefer descheduling of cannabis, so that we can start conducting human trials and seeing what it does. My interest in it, I won't start a therapy on like my most severe patient. I won't start an isolate on my cardiac patient. If my patient decides that they want to consume cannabis, because now we have to, this is a practical thing, right? We can't force anyone to do something or not to do something. But what I always suggest is cautious use of it until we know more. All right. I'm a big fan of recommending cannabis in my patients who are at risk, but not necessarily for my patients with known coronary disease. All right. The other element of that is the drug interaction. We know, like for example, CBD. CBD is going to increase the concentration of the statins and the beta blockers, and because they share the same metabolizers, and so how that impacts patients who are already taking aspirin and Plavix and statins and beta blockers or who are on Entresto. We don't really know that yet. And I certainly won't experiment on my patients with that. And so right now we're looking at healthier patients and seeing how that alters their metabolome, um, their inflammatory marker expression. And we'll start there and generate information there before extrapolating it to our sicker patient population.
Have another question from the chat here. Um, Wanted to ask your perspectives on collaborating and the importance of involving a pharmacist in either research or a clinical setting when looking at routes of administration and dosing for medical cannabis and therapeutics.
We have to. We have to. I mean, that this should be true of everything. Everything involving someone's health should be viewed from a multidisciplinary approach. That's true across the board, but especially in potentially novel therapies. I think this especially just given the variation in routes of administration, we have to include our pharmacists, especially with respect to the drug and drug interaction. As a clinician, as an MD, we're aware of the major issues, but I think we have to get to the crux of, okay, how does this really impact this patient, given that this patient is already on X, Y, and Z? Can we safely wean the patient off maybe some of their pharmacologic agents and replace it with cannabis. We're seeing a lot of that. We're seeing a lot of patients replacing their medications with cannabis. How do we do that in a safe manner? All these are all questions that remain because we just don't have the research. There's such a paucity in research.
We got one more question here from one of our team members at Drexel, going off of one of the previous questions from Sandhya. How would you be able to account for potential medication interactions if patients are prescribed other medications for the underlying condition?
Yeah, so that's sort of what I was just getting at. That's where the biggest challenge is. I think that's where we see the greatest gap in information. We're not talking about drug-drug interactions right now. We know the metabolizers, we know the cannabis metabolizers. And so, I always look at, well, what other medications are actively metabolized uh, um, by these drugs. And so, it becomes if I put someone on a full spectrum CBD, I may lower their beta blocker. I may lower their statin, but again, I'm not even at that point yet. Most of the people who I recommend um, cannabis for are the ones who are not taking as many medications, all right, that have potential drug-drug interactions because we're not there yet.
So I think we have time for two more questions. I do have one here pre-prepared, kind of getting to your point about gaps in the literature. Where do you see kind of the biggest gaps in the literature, and where would you like to see researchers focus more on to help inform you as a clinician?
Dosing, I see the biggest gap in dosing. Um, again, I presented this slide where I said ultra low, low, moderate, and high. What does that even mean? Everyone has a different classification for what that even means. Um, I'm a big fan of more of the acidic extracts. So I want to see more comparative studies between the acidic extracts and the neutral compounds. Um, Again, we're always going to be looking at, variations in chemotype. I didn't even touch on because that's a whole nother conversation about the interaction between cannabinoids and terpenes. Like I only know of maybe a handful of cannabinoid terpene compounds that I suggest, like for example, if I have someone that has a diabetic neuropathy, I'm a big fan of CBD with beta caryophyllene because there's data that shows that benefits these patients. Um, and so, it's we have a long way to go. And in fact, I think the only way that we're going to extend our understanding without, just trial and error, which is what a lot of clinicians are doing for their patients, I think we're going to have to change how we view the body, its disease states, and its corresponding therapeutics. And by that, and this is where the whole idea of quantum medicine comes in. I think we're going to have to develop a better understanding of physiologic energetics. You know, disease is an energetic anomaly. That's it's sort of, when we talk about functional medicine and we talk about what the root cause of these disease states are, is really energetic dissonance, all right, and desynchrony and cellular communication. And so understanding how the body interacts with itself on an energetic level, I think that's when we'll gain a better understanding of how to treat it when disease does occur. And I think I'm talking light years from now, but the way that we view drug therapy, cellular communication, I find to be highly inadequate. This whole lock and key model of that the way that the body communicates with itself, I find to be highly inadequate. All right, the body is far too complex and fast and specific for that to be the primary mode of communication and primary mode of drug therapy. I think the body communicates and responds to drug therapy more like when we talk on a cell phone. It's frequency based, it's energetic. All right. Each one of these compounds gives off its own resonance, its own vibratory signature. And we have certain cells and certain pathways within the body which responds to those frequencies. That's how the body communicates with itself. But we're not even really thinking on that level yet. It's an emerging area, and I do think we're going to get more into that. But I think that's the only way that we're really going to learn how to use these thousands of different strains or hundreds of different strains um, to impact a person. Because I don't know how much you all know, but you can give the same strain to two different people and have two very different effects. And I think that's because their baseline vibratory signature is different. And so they're going to respond differently to the same therapy. But again, I'm going off on a whole different level because I challenge the way that we view the body in terms of how it communicates and responds to drug therapy.
Great, thank you for that. We have one last question. Hopefully, can make it quick for you here. Or do you have any recommendations for people on the call? How can they be more involved as a patient advocate in this space?
Mm. Um, that's a good one. And I actually asked this we just had our research symposium out here in New York. And I asked the keynote, how can we get the scientific community to better engage with the culture? And I think that it's a little different, but it's somewhat the same. Because I think a lot of what we know as scientists is coming from the culture. The people who have been doing this underground and what they're calling the legacy market now. They're really the pioneers and drivers behind this reemergence of cannabis back into the forefront. And I think if we can better engage with each other, have those conversations, your doctor should be willing to at least have the conversation, be open to the discussion, even if they're not necessarily knowledgeable about cannabis. I think we need to educate the educators. Meaning, I think learning about the endocannabinoid system should be mandatory, just like learning the cardiovascular system. It baffles me how you have this major regulatory system that we've known about since the 90s, but it's not part of our medical education curriculum. I think we have to teach the teachers. You have to educate the educators. I will hope that patients, through your lived experiences with the plant, that you take that back and, you become the teacher for your provider. I think this is an area where we can all learn from each other. And that's actually one of the greatest things about cannabis is the great connector. So many people have touched this plant and benefit from this plant. And so I think we can all learn from each other and how to best use this plant.
Great. Thank you very much, Dr. Hinson. I did want to give a shout out to our upcoming speaker series. January, we'll be talking about some new research that we have at Drexel on cannabis and parenting. And then in February, we'll have the Oregon Liquor and Cannabis Control Board talking about their cannabis and hemp testing study. But thank you so much, Dr. Hinson, for this presentation and for a meaningful discussion around cannabis and the Q&A. Look forward to following your work moving forward, and hopefully we can collaborate sometime in the future.
Absolutely. Thank you.